Good afternoon, everybody. As Matthew said, I'm Suzanne Lepage, and it's a pleasure to be presenting to you today and sharing with you a little bit of explanation of how your health insurance at work works. And like any presentation, this is a high-level overview, but hopefully it will give you more information than you already have today and help you navigate the coverage that you have available to you today. So I'm going to start out by distinguishing how private and public drug plans differ, and a little bit of an overview of how the market is organized and who the key players are. I'll tell you a little bit about the drug plan designs, and you'll see why it's not so simple to just say, is my drug covered or not covered? There's a lot of variables that come into play. We will talk a little bit about the cost pressures that private drug plans are facing, and as a result, some of the emerging trends or plan designs or restrictions that are being put onto private drug plans to manage those. And lastly, I'm going to provide you with a bit of an overview of how to inquire about your private drug coverage, and so to equip you with a starting point so that if you are navigating for yourself or a family member or someone you know that's close to you, it's a bit of a step-by-step approach about how to approach it. So with that, let's get started. So one of the key things to think about when you're comparing the public drug plans that are available to us through the provincial government and the private plans is, for the most part, employers view their drug coverage and their health benefits as part of the overall compensation for their employees that work for them, and it's not necessarily about providing for their health. And I think that's a big shock to some people. And I say that with the most respect, in the sense that they're not necessarily experts in health. They're experts in the business or the industry that they're in, and they are looking to make sure that their total compensation package that they provide to their employees is competitive, so that if you're in the banking industry, they want to make sure their benefits are competitive with the other bankers. And if you're an auto worker, then they may have to have benefits that are mandated through the collective bargaining agreement. But overall, the benefit package is part of that overall package, which includes salary, retirement benefits, vacation, and all other benefits. The other thing that's really different is that it's not necessarily the same transparency. When we're dealing with public drug plans, they're delivered by governments. The representatives are elected by us. There's a certain expectation that there's that open discussion and transparency. With a lot of the situations with private drug plans, is they're viewed as more confidential business-to-business transactions. So just like you wouldn't necessarily know someone's salary range for different jobs, you may not know the benefit plan for certain jobs within an organization. Is that it's viewed as a business agreement between, so the employer and the insurer have an agreement about what their benefit plan is, but it's not necessarily in the public domain or shared. And also, the other thing is some of the major players in the industry, and we'll talk about them in a minute, like insurance companies and pharmacy benefit managers, they're all competitors in this business. So they're always concerned about their competitors gaining market intelligence about how they do things, because they're all competing with each other to be the best in the industry. So those are some important distinctions. The other thing that's important to know is, generally speaking, specific drug coverage decisions or criteria are rarely communicated publicly. So it's not like, again, where major decisions, like in the government, there's consultations and chances for people to provide input. Most of this is done more quietly. If you're a plan sponsor, which is the name they use for an employer who sponsors the benefits, and we'll talk about those in a minute, or the advisors or consultants they use to set up their plan, they can get information about their plan because it's their plan, and so those customers will receive that information. And the plan members, which are people that are receiving the benefits, they can be employees or union members, they can access their own coverage information, but usually in a confidential, secure manner, so either through a call center or secure web portal where they will access that information based on their specific certificate and contract number. So again, this information isn't necessarily in the public domain. So it's really important to understand that this is a bit, can be a bit challenging to try to access all this information. So let's talk a little bit about who the players are in this landscape. And the first thing to remember is that the plan sponsor is the ultimate customer in the private insurance market. A lot of people think of the insurer, but in fact the insurer is a supplier to the plan sponsor. A plan sponsor is typically an employer, but not always. Sometimes the sponsor of the plan could be a union who manages the benefit plan. Sometimes it can be a professional association, for example, a bar association or a chamber of commerce. So whoever is sponsoring by paying and deciding what's covered is what we call the plan sponsor. Most often we think of the employer, but not always. And they typically decide what kind of coverage they want to provide to their plan members, which are their employees or the union members or whoever is benefiting from the benefit plan. They decide on what coverage to provide based on, again, competitiveness in the type of makeup. And if there's a union involved, then the union will sometimes bargain for the benefit plan, and they will, the collective bargaining agreement will decide on what kind of benefits should be provided. And, you know, ultimately plan sponsors for the most part are busy people, busy running their business or their organization, and they may not have the skill set to understand benefits very well and compensation. So some of them, a lot of them, over 75% of them use some kind of benefit plan advisor. So just like you might use an advisor to help you with your own personal financial plan, your home insurance, your car insurance, there are a group of benefit plan advisors who whose responsibility it is to provide plan sponsors with advice. And so they are engaged by them. They're frequently paid by commission on the benefits they sell. Some of them work on a fee for service, but their role is to provide expertise to the plan sponsor to design their whole benefit plan, not just their drug plan, not just their health plan, but everything to do with their benefit plan. And doing so, they will help them select an insurer to meet their needs. And so that what will happen is that the plan advisor will work with the plan sponsor to determine the best, maybe more than one benefit plan design option for them, and they'll actually submit it to the insurers in a request for proposal and ask the different insurance companies in Canada to bid on that benefit plan to show them what kind of rate they would offer them, and they would also do a proposal based on the type of plan design they can offer and how they can provide better benefits coverage to their plan members versus other insurance companies. And so what we see is that the insurers are all competing with each other to provide the best benefit package. And really, plan sponsors decide on choosing their benefit plan provider mainly on cost, so who can provide me the lowest cost, but they'll also look at service and the different ways of offering. You'll see later when we talk about benefit plan cost pressures, more and more lately they're also looking at how can someone help us keep our costs low, because they are seeing costs go up. In Canada, we have about 15 different insurance companies, give or take, depending on who you define as an insurance company. And then we also have organizations called pharmacy benefit managers. And pharmacy benefit managers are responsible for managing the pay-direct drug benefits for insurers. And so sometimes an insurance company will contract out. So for example, there's one large pharmacy benefit manager called TELUS Health, and they are the pharmacy benefit manager for Sun Life and Great West Life. And then we have others like Express Scripts that are the pharmacy benefit managers for Manulife. And what a pharmacy benefit manager does is they are responsible for, managing the relationship with the pharmacies. And how they do so is that they are responsible for managing the computer network and the real-time claims adjudication between the pharmacy benefit manager and the pharmacies, and they do so with the electronic platform, and they also have a signed agreement. So one of the things they do, which is where the name pharmacy benefit manager came from, is they're responsible for managing the agreement between the pharmacy and the insurers. So the types of things that will be in that agreement is how they submit a claim, what information needs to be included, how they'll be paid, what the limits are. So they sort of manage the the way that that claim is adjudicated. And so in Canada, we have about 3 major pharmacy benefit managers. We also have some insurers that don't contract out their pharmacy benefit management, so they act as both an insurer and a PBM. And there's about 8 of those in Canada, and some of the common ones you would think of would be Green Shield and the Blue Crosses across the country, where they act as both a PBM and insurer rather than contracting that out. So those are the key players in the industry, and we're going to talk a little bit now about how this whole industry works together. So when it comes to plan design, when we specifically look at drug plans, because that's what most people ask about, is that it is the plan sponsor who decides on what coverage will be provided. Now there's one exception to that. If anybody's on the phone line from the province of Quebec, the Quebec government, through a program called RAMQ, has a minimum level of coverage that every employer must provide. They can provide more generous coverage than the RAMQ formulary, but they have to provide at least that level, and there's also levels of reimbursement. But in the rest of the country, drug benefits are optional, and plan sponsors can provide as little or as much coverage as they want. And so to that effect, what we're going to do is talk a little bit about all the different plan designs that are available to plan sponsors to choose from. And it's very much what I would call menu driven, in terms of they can pick and choose a little bit from every row and column in this chart and put together the plan design that they want. And by setting up this plan design, they will then get a quote for the price of this plan design based on the makeup of their group. And when I say the makeup of the group, it actually means that how many employees do they have, what are their ages, what is their gender, what province do they live in. So they get anonymized data about the plan, but it allows the insurer to determine the risk. Because ultimately, what the insurer's job is to determine the risk for the plan design that the employer is choosing, and from there determine the premium to charge them. So let's talk a little bit about the different plan designs. The ones that most people talk about in the industry are formularies. And formularies are very important because that's the list of drugs that we start with that are covered. However, we'll see pretty quickly that there's more than that involved. So let's first talk about, we're going to start on the far right-hand side, which is the most generous coverage available. And that's what we would call prescribed benefits of prescribed drugs, and also means over-the-counter drugs. So there are some plans that are very generous and include every drug the doctor would prescribe, including over-the-counter, as long as it's dispensed by a pharmacist. So Claritin, which is available over-the-counter, or Tylenol would be covered under these plans. As you can imagine, they're quite generous, they're quite expensive, and they're not very common, but they do exist. And I put them in here to sort of show that there's a broad range available. The one that most people talk about or are familiar with in Canada is what we call a prescription by law plan. Some people call it an open plan, but we'll see in a few minutes that there's very few plans that are truly open anymore. But what it means is that if the drug legally requires a prescription, it will be covered by the plan. And so any drug that would come to market is covered by this plan. But as I said, it's a bit of a misnomer, because if we only look at this layer of coverage, we're not really seeing the big picture. There are some plans that choose to mimic the provincial plan in which they operate. So if you're a plan sponsor in Ontario, you may mimic the Ontario drug benefit, and so your private plan covers the exact same list of drugs as the Ontario plan. Or if you're in BC, you mimic the list of drugs that are on the BC PharmaCare plan. So that's an option that a plan sponsor can choose. We also have some plans that offer a managed formulary, and what that means is the formulary is managed by a third party, so that can be the insurance company or the pharmacy benefit manager or an external organization, and they make clinical and cost-effectiveness decisions on which drugs are covered and which aren't. So it allows some plan sponsors to manage their costs because they don't cover every new drug that comes to the market. And the last on our far left is 2 categories, actually. It's a bit of a cheat because I'm using that one box. But sometimes we have frozen formularies, which are formularies that are frozen at a point in time. And what they do is they perhaps cover all drugs that were available in the market as of 2013. And they freeze it so that no drugs come off that list, but also no new drugs come on that list. And although it's kind of a short-sighted plan design, Some people want it. And again, what an insurer will do is provide a quote on that. At the point that they get the RFP, they may or may not have the ability to suggest other plan designs. And then the last one is what I would call a customized formulary. So they may be a healthcare organization, maybe a hospital or a pharmacy chain, and they have the skill set internally to manage their own list of covered drugs, and so they give that list and make those decisions and just tell the insurance company what to cover or not cover. So in most cases, people will stop here, and they'll say, is my drug covered by the formulary or not? But in reality, it's way more complex. And one of the main reasons for that is that there's other plan design features that come into play. So in this row in copay, these are different categories of copay. And bear in mind that the columns don't necessarily line up. You can choose any of the options with this row with any of the options in the above row. So there's no sort of matching up column by column. So in terms of copay, on the far left, a plan sponsor can choose whatever coinsurance they want. So they can choose to pay 100% of the drugs, they can choose to pay 80% of the drugs, or they could pay 50% of the drugs. So they would determine how much they're willing to pay towards the cost of the covered drugs. Some plans have a flat copay, which is a flat dollar amount. So the plan member could pay $3 per prescription, or perhaps they could pay $25 per prescription. So again, that's determined in the plan design. We also have some plans that have deductibles, and a deductible can be $50 or $5,000. It's often combined with the other health benefits, and so it's what we call a combined deductible. But it's just like your car insurance or your house insurance, where you pay the first X amount of coverage. After that, the plan kicks in. We have another plan design called sliding coinsurance, and what that means is we take that 80% coinsurance, for example, and what they say is that at a certain point, that 80% will slide up to 100%. The most common way we see that is when a plan member's out-of-pocket amount, so let's say you have an 80-20 split and you're paying 20% of the cost. When your out-of-pocket costs potentially reach $1,000, that's one example, then your plan will start paying 100% of your benefit costs. So that's an example of how that can be done. And then we also have, which are becoming more common, is what we call multi-tiered plans. And what multi-tiered plans do is they allow you to have two formularies. So you could have the list of provincial drugs that are reimbursed at 100%, and then all the other prescription drugs reimbursed at 80%. So at that point, you have two plans, two tiers, two different types of reimbursement levels. The next category I'm going to talk about is limits. And what limits are is different rules that are applied to the plan, again, built in as part of the plan design. So one of the first ones that people hear about is therapy class inclusions or exclusions. And so this is where the plan has decided certain classes that they may or may not want to cover. An example of that could be smoking cessation drugs. Do they want to include them or exclude them? Or potentially it might be birth control or sexual dysfunction drugs. So there's a wide variety of categories that they could choose to include or exclude. Or they may put limits on it. So one that comes to mind is, we'll cover fertility drugs, but maybe only $2,000 in a lifetime. So these categories would have specific names and exclusions in the plan design. Not as common, but we do have some programs that have what we call trial script, and those are for drugs that are for plan members that are drugs that are complex that people could maybe not tolerate well. So rather than giving someone a 30-day supply of some of these drugs, what they do instead is maybe let them start on a 7 or a 14-day supply to start and make sure they're well tolerated before they fill the rest of the prescription. That's a cost-effective way of avoiding wastage. We also have some products that have a day supply limit or a quantity limit, and those usually are aligned with the medical practice of what would be reasonable and customary for usage of that drug. We also have pricing and maximum limits, and some of those that are built in would be, the first one is allowable price, and so there's some checkpoints in the claim system built in to say what would be a reasonable allowable price for this drug. And the idea that is they want to make sure that they're not being overcharged for that drug or having a too high of a markup be applied to that drug. So that's controlling the allowable price. We often see drug plans that have generic pricing turned on, and what generic pricing means is if the brand name drug has a generic alternative that's been approved by Health Canada, the private plan may limit the reimbursement to the price of the generic drug. So you can still get the brand name drug, but you may be required to pay the difference between the brand and the generic. We also have plan designs that may have annual or lifetime maximums built in, and that's done to limit the plan sponsor's risk. And sometimes these maximums are combined with all the health benefits, or sometimes they stand alone for the drug benefit. So again, that's a plan design option that's chosen by the plan sponsor. And lastly, we can see dispensing fee caps built in, and that would limit the amount of dispensing fee the plan would pay. And so that, for example, if the dispensing fee cap is $6, if you went to a pharmacist that charged $11, your plan would pay $6, and you'd have to pay the other $5 out of your own pocket. But as you can see with this, this matrix, is that coverage is quite complex, and you have to look at all these variables to completely understand what's covered. So for example, if you look just at the top level and you'd say, wow, I have a prescription drug plan. Every drug is covered. But if you don't look down at some of the other factors, for example, the fact that there's a lifetime maximum, if you don't have all that information, then you don't completely have all the information about the drug plan design. So you need to look at this whole matrix when you're looking at the drug plan and not just at the formulary and what's listed and what's not listed. The other thing that's important to note is that every insurance company offers most of these variables. So it's not really technically correct to say, does Great West Life cover this drug? Because there are plans at Great West Life or Manulife or Green Shield that have managed formularies, and there are plans that cover the prescribed drugs, which includes over-the-counter. So they're all different types of plan designs, and so you really can't look at that. You have to look at what that individual plan sponsor has chosen for their plan members. But what makes it even more complex is you can have two categories of employees at the same employer that have different coverage. And so that's why it's really important to navigate or investigate the specific coverage of the specific patient that's inquiring. So let's talk a little bit about private drug plan cost pressures. And really what I'm going to do is share with you one of the large pharmacy benefit managers, some highlights from their drug trend report to have you understand what some of the costs, how the costs have grown in the previous year. So Express Scripts Canada is a drug pharmacy benefit manager, and they provide a report every year to plan sponsors and plan advisors about how costs have gone up. In 2014, their analysis of their block of business said the annual drug spending went up by 2.7%. And they categorized what they would call traditional prescription medications and specialty medications. Specialty medications include high-cost drugs that require special handling, special storage, and probably patient training. And they include biologics, but also include some of the more complex oral medications. And traditional medications remain are the rest. And that category of traditional medications, prescription medications, those costs declined by 0.3%. And one of the two main reasons for that is many of those drugs have gone generic, and also we've also seen generic price reform come into place where many of the prices for generic drugs have gone down due to government legislation. In 2014, private plans saw the 12.1% increase in spending for specialty medications, and you can see here what drove that. So the cost per prescription has gone up as well as utilization. The key thing to note is that it only represents 2.2% of all the claims that they receive, but actually over 26% of the spending. And according to their projections, it could be 35% in the next 4 years. So this is an area that we're seeing a lot of attention being paid to because these are the ones that are growing exponentially. They also noted that the top 1% of all the claimants actually comprised of 28% of the total spending, and that total spending for the top 1% of their claimants equaled the same spending for the bottom 85%. So it is really those people who are the sickest that have most of the drug spending. And so this is why we're starting to see private drug plans, the cost of their premiums are going up, and therefore they're looking at ways to manage these costs because nobody has an unlimited budget for things that, when they're running their business, so they have to keep their costs manageable in order to sustain them. So we're going to talk briefly about some of the emerging trends in the private market. And what we're going to talk about is some of the things that are relatively new to the market, although not completely new. So the first one is something called case management of drug claims. And case management in the insurance industry is nothing new. It's been done for years on disability claims. So if anybody on the line has ever managed someone who's gone off on disability or gone on disability yourself, you would receive a disability payment from your insurance company, but you would be assigned a case manager, and that case manager would be making sure you got the appropriate treatment. They would be asking your doctor for updates, and they would be trying to manage your condition and help you get back to work. Well, nowadays we have drug claims that are equal in cost to some disability claims, and those drug costs are an investment, and they're there to make sure you get the stay at work and not go off on disability, but insurers are starting to apply those same concepts of managing the condition, so they're managing the patient and their drug claim the same way they manage a disability claim. And so if you're taking one of the medications they deem that they want a case manager assigned to, is you may actually have a contact via the insurance company that will work with you and your doctor to ensure you're getting the appropriate treatment, that you're seeing the health outcomes that are expected, that you're getting dosed appropriately, and that's what a case manager does at an insurance company. So it's different than the case manager you might be dealing with a pharmaceutical company patient assistance program. They're working on behalf of the insurance company and your plan sponsor to ensure that you're getting cost-effective treatment for the investment that they're making. We've also seen an increase in what I would call mandatory generic pricing. So in the past, we mentioned earlier that generic plans reimburse up to the level of the generic price when a generic drug exists. But one of the things that happened in the past is the doctor could write no substitution or no sub on the prescription, and the generic drug plan would allow the patient to be reimbursed the cost for the brand name drug. What we're seeing more of now is with mandatory generic pricing is that writing no sub is not sufficient. What would have to be done in order for the patient to be reimbursed the cost of the brand name drug is that their doctor would have to provide medical evidence that they can't tolerate the generic drug, and then they would review that and only then allow the patient to be reimbursed the cost of the brand name drug. We're also seeing an increase in preferred provider pharmacy networks with some of the major insurance plans, and that means that they've signed an agreement with a pharmacy network to provide lower cost medications to their plan members, and it's a way to save on the acquisition costs through economies of scale. And some of these plans are optional to use the preferred pharmacy network, and some of them may be require you to use their preferred network in order to be reimbursed. We're also seeing a little bit of what I call therapeutic substitution, and what I mean by that is that the private plan may pay for a different drug than your physician has prescribed. And so because the coverage is becoming more complex, you get prescribed a drug, and in going to contact the insurance company or going to your pharmacist, you find out another drug is the preferred drug or the covered drug. And what that means is you having to go back to your doctor to get that prescription changed, or your pharmacist will have to work with the doctor to see if they can change the prescription over the phone and have you get another drug prescribed. The insurance company isn't telling you what drug to take. That's still up to your doctor to tell you. However, they may restrict coverage and not cover the drugs that you were prescribed. And so that's where we're starting to see a bit of a shift in terms of moving from very broad coverage to more specific coverage of only certain drugs. We're also seeing situations where specialty drugs are being more targeted, and so some of those examples were the case management of drug claims. That's really happening on specialty drugs, and for example, the other example is the preferred pharmacy networks are also being targeted at specialty drugs. So they're trying to do a lot of tactics and strategies to reduce the cost of specialty drugs through different wide variety of tools in the drug plan. And we're also seeing a growth in plans moving to more formulary, so whether they decide to mimic the provincial formulary or whether they decide to move to a more managed formulary, if they don't think that they can afford to cover all the drugs that are out there, they might think that someone managing the formulary for them will be a way of managing those costs. I also have a little footnote at the bottom, and that these trends are not mutually exclusive. You can have many of these happening at one time, so the idea is it's not sort of they pick one out of this list. You can have 2 or 3 of these things happening at one time on any one plan. So, and sometimes they're hard to determine what all the moving parts are because it's happening sort of behind the scenes. It's not necessarily apparent to us what's happening at that point of claim. The next section I'm going to talk about is what to do when a drug isn't covered. But I'm actually, Matt, if that's okay with you, I'd like to pause and see if there's any questions about the plan design features and some of the emerging trends before I move on to tips about how to navigate coverage and what to do when your drug's not covered. So can we pause there and see if are there any questions for me?
Yeah, there are a couple questions here. I guess what I'll do is just read them up for you, and then you can take a stab at them. Wellum says, I wondered if you could further flesh out the differences between flat copay and deductible copay options.
Sorry, can you repeat that?
He asked, he's wondering if you could further flesh out the differences between flat copay and deductible copay options.
Oh, okay. So a flat copay would be on every prescription. So every prescription, you might have to pay $3 per prescription. A deductible is usually a one-time only. So the idea is, so that's more like car insurance where you pay, like car insurance, you may pay the first $300 and then the plan picks in. So maybe your deductible could be a $50 deductible. You pay that at the beginning of the year and then everything else is paid thereafter, or a $500 deductible. So that's the difference, is one is every prescription and one is usually one time only in the year. Okay. Matt, you're going to have to read these for me because I'm having a hard time seeing them on my screen.
Yeah, no worries. I can take charge of this. So the only other one is from Stacy, and she asks, do you assume that these specialty figures will change dramatically with the Hep C spend? And I'm not sure if that was in reference to one certain slide that you were on a few minutes ago.
Yeah, so yeah, I mean, there is a whole section in the Express Scripts Drug Trend Report about how significantly these Hep C costs have changed, and I have one figure that I just have a note on, and I'm just going to flip to it. And what Express Scripts noted in their data is between Q1 2014 and Q1 2015. Their Hep C drug cost growth grew 10 times in that period. So it gives you an idea that, yes, it has a huge impact. And they actually did a separate section on the report last year, and I suspect they'll do one this year. So it did have a huge impact on specialty drug trend costs.
Okay, there you go. And there's one more that just came in. Any
other questions, Matt? Before?
Yeah, there's one more from Pamela, and she's saying 19 million plan members in Canada. With a Canadian population of 35 million, does that mean about 52% of people in Canada have coverage?
Exactly.
There you go.
Exactly. So yeah, so there are lots of people that don't have coverage, so people who are self-employed, people who are underemployed, or there are still employers that maybe just don't offer coverage, period. So the only thing I would say, though, is there's no one reliable source for that. So this comes from different estimates, and that's why it's sort of approximately, because there's no one reliable source to say how many people have coverage in Canada. It's not something that's sort of registered in your census or anything like that. So those are best estimates.
Okay, and that's all the questions for now, Suzanne, so I'll let you carry on with the rest of your presentation.
Okay, great, thank you. So the question I often hear from patients, and this could be more formally or it can be at a cocktail party, is, well, my drug's not covered. And so the question I get is, well, then what do I do about it? And I say the strategies are situational. What you do has a lot to do with why your drug isn't covered. And as you saw earlier, we talked about the fact that coverage is quite complex. And so I have a bit of a cheat sheet here of the different reasons a drug may not be covered and some things to think about. So one of the things you'll see, I'm going to give you a list of questions to ask in the next section, but one of the things is really important to ask is why the drug is not covered. And so in the far left column in this chart, I have the reason the drug isn't covered and then some suggestions of potential strategies. So one of the first things is your drug may be so new that it's still under review. So you've given them the drug identification number, and they'll even say, like, I don't have this drug in my system yet. So it's not that it's covered or not covered, but it's just so new it's not even in there yet. And so the idea is that you need to make sure you ask them when the decision will be made and make sure you diarize to call back at that point in time. And so I've seen that happen a lot where, you know, the drug gets approved and you can't wait to get it, but sometimes the drug reviews can take 1 month, 3 months, 6 months to review. So it doesn't mean that it won't be covered, it's just sometimes it's taking some time. Now, another reason that your drug might not be covered is that you have a drug plan that mimics the provincial formulary. So you live in BC, your employer has chosen a plan that mimics the BC provincial formulary, and at the point in time that you contacted the insurance company, the BC formulary, the pharmacare formulary has chosen, or maybe not chosen, but hasn't made a decision to cover that drug, and therefore the drug would not be covered on your private plan because they mimic it exactly. And so you need to monitor and keep in touch with when that drug would be covered by that provincial plan, because at the time that the provincial plan makes a decision, the private plan mimics that decision. So it really is the employer or the plan sponsor has chosen to mimic that plan, so therefore that's what they cover. You may be asking about a drug that's part of an excluded or limited on the drug plan, and so the only way that that drug will be covered is if the employer would actually change the drug plan design, because the insurer is not covering it because it's a drug that your employer has chosen not to cover. So that's you know, one of the reasons that you may not have a drug covered. The drug could be a managed formulary, and that means that whoever the formulary manager was reviewed the new drug and decided not to cover it. And those ones are more challenging because those reasons for not covering are not always in the public domain, and it's really going to require you to be persistent to find out why they decided not to cover the drug, you know, find out about clinical or cost effectiveness, and then work on developing a strategy to appeal the decision. These aren't always easy, I will tell you that right now, but I'll have some tips on how to appeal for a decision that's made in the next section. You may also have a situation where specific criteria must be met for the patient to be covered for the drug, and so it might be based on their diagnosis. These are what we call prior authorization or special authorization, where the insurer may only pay for certain people who have a certain diagnosis, who have gone through specific prior treatments, which may be called step therapy. They may have, if it's an infused drug, they may not pay for an infusion in a hospital, but they may pay for an infusion in a private clinic. But for whatever reason, after reviewing the criteria for that particular patient, they decided that they're not covered. So again, you need to ask some specific questions of the formulary manager on why they decided on this criteria. And if you feel through your work with your physician or with other specialists that this criteria does not align with approved indications or guidelines, then there may be a case to develop a strategy for an appeal. And so again, we'll talk about that in a minute. You also may have plans, and this is becoming more common, where they're actually wanting the patient to explore public coverage first before the private plan will kick in. Most private drug plans were designed back in the 60s to wrap around public coverage. So where public coverage was not available, the private plan would kick in. So it's designed, and the premiums are determined based on the fact that the government coverage would be the first payer. And so in that sense, we're seeing some plans where they're actually saying, gee, for this, in this particular province, for this disease or for this drug, there may be a public option available. We'd like you to explore that first. And so the first thing you need to do is get to apply for that alternate coverage right away, but also the chance to maybe ask for some interim coverage from the private plan while you're waiting for the government plan to review, especially if you know there's a delay in getting that government coverage review. That may or may not be possible with the insurer, but it doesn't hurt to ask. And the last one is, and this is the most challenging at all, is that the drug is actually covered, but the patient reached their individual maximum. And again, that's really going to be a requirement to have the employer change or remove the maximum, or allow a patient exception, but that would end up costing them more on their drug plan, or else exploring other potential coverage. And that, for example, is there a catastrophic drug program in the province in which you reside. So none of these are going to be easy answers, simply because the private drug plan is set in a contract for at least a year at a time, and the insurance company and the employer have entered agreement what will be covered and not covered, and they've determined a rate for that. And so any time that an insurer would make an exception to the plan that the employer sought, then the insurer would be taking on additional risk. And so that's why you'll see when I walk through the steps for you as a patient or supporting a patient is you really need to potentially talk to the employer who's ultimately paying the bill for the benefits. So with that in mind, I'm going to tell you a little bit about what I call how to inquire about your private drug coverage. So you're hanging up from this webinar today, and you're going to call the insurance company this afternoon to inquire. Well, here's the things you need to be ready with. First of all, if you have a drug plan, or maybe your spouse has a drug plan, or you both have a drug plan, is make sure you have, before you call, the contract or policy number. So this is the unique number that goes with that employer or that plan. And you'll also be assigned a personal certificate or identification number, and you need to have that ready, because those are your two unique identifiers that help them figure out what coverage you have specifically. I also suggest that you get a copy of your benefit booklet that outlines what the employer offers you. So sometimes that booklet is available through your HR department. Sometimes it's available online if you have an online portal. But make sure you have that, because that is sort of almost like a legally binding document that explains the coverage, and have that ready. You can look up the number for the insurance company. Sometimes it's on your benefit card. Sometimes it's in your benefit booklet. Usually they have a website. And when you're going to call the insurance company about a drug, you need to have the drug name, and you also need the drug identification number, because different doses sometimes have different drug identification numbers. If you don't have that, your pharmacy can provide that for you. So the next step is really important. After you ask about if the drug is covered, and when they say it's not covered, if you remember from the previous section, it's really important to know why the drug is not covered. And you got to remember that the customer service representatives you're dealing with are dealing with a computerized system, which is very basic. It allows them to do an inquiry: is it covered or not covered? And so, you know, the why it's not covered is maybe not readily available for them. So you're going to have to be a bit persistent. So the first thing you do is you want to ask them about, can you explain to me why it's not covered by my drug plan? And, you know, they could just say, well, your plan doesn't cover it, ma'am. You know, sir, that's the plan that your employer chose. And then you can maybe ask something, well, you know, I'm not really familiar with insurance coverage. Can you help me understand why this particular plan does not cover this drug? I have my benefit booklet right here. And could you explain to me why this particular drug is not covered? And again, if they're not able to help you because they may be trained just to provide basic answers, you say, well, can I speak to someone who can? Maybe you can transfer me to a supervisor who can explain this more to me. You have the right to have your coverage explained to you and why a drug isn't covered. Sometimes they'll suggest you check back with your employer. But again, for privacy reasons, you have the right to say, I'd rather not discuss my coverage or my medical condition or my spouse's medical condition with my employer. I really don't want to have that conversation, so can you please, to protect my own privacy, explain to me why this drug is not covered? Now again, the person that you're talking to may or may not be able to help you, but they can certainly take the information away and look into it for you. So make sure you take their name and their phone number and the date you spoke to them, and to ask them when they're going to follow up with you. So it might require record keeping, but I would suggest that you try to make sure that they look into it and get back to you. Now the best result could come from talking to your employer, but that requires you to disclose your medical condition. But the reason I say this is because the plan sponsor is the ultimate one who decided the drug plan coverage that you have in place. And so also, they're the only ones that can really ask for an exception. And so these are some of the suggestions I have. So the thing is, first of all, is sometimes an exception is also called extra contractual coverage, and that means it's outside of the contract that they set up. Now, the ability to request or negotiate exceptions depends a lot on the size of an employer. As you can appreciate, a plan with 10 employees probably doesn't have as much negotiating power as a plan with 10,000 employees. So, and also depends on the financial arrangements they have with the insurance company. But I think the best bet is for you to develop a business case on why the employer should cover the drug. Most companies are businesses, and so they very much appreciate the business case. And so what will be the benefit to them as an organization to cover the drug? I mean, you can even make that case for a family member. If you're taking care of a very sick child and this drug will only have to be dosed once a day instead of 3 times a day, then maybe that's a benefit for you not having to try to get home at lunchtime to dose your child. So to think about it from the employer's perspective of why they should cover the drug. If necessary, you can try to get assistance from a physician or a support group to help make the case. Make sure you put the request and all the supporting evidence in writing. You want to always have a written record of it. And then arrange a meeting with your manager or human resources or the benefit department as appropriate to make your case to them about trying to get coverage. So hopefully today I've given you a little bit of an overview of private drug plan coverage, some suggestions on how to inquire about your coverage and navigate the healthcare system. And I left enough time at the end to make sure we have times for questions and discussion. So with Matt, that's the end of my formal presentation, and I hope that we have some more questions for discussion.
Okay, at this point, I'm still waiting for more questions to come in, unfortunately. So for now, we'll, as I say that, we have one come in from Nancy, and she is asking, can you comment on private payers and the potential for national pharmacare?
Oh, that's a great question. So it's hard to say because I don't work for a private payer anymore. I have in the past. So I'll give you just sort of my personal opinion. One of the things about private coverage is that, and the difference from public coverage is it can be way more generous than public coverage. And one of the things my fear is that when we talk about national pharmacare, it will bring us to a common denominator, which for the people who don't have coverage today, it will certainly bring them up a level because they'll have some coverage. But if everybody goes to the same standard coverage, then we won't have people who have maybe more generous coverage. And so that's a big risk. And also my personal opinion is that certain employers want to provide better coverage simply because it's part of the compensation package, or it's really they have key employees that they want to make sure stay at work, and so they want to have that flexibility or ability to provide the best coverage possible. And so I think if we move to a national pharmacare model, we could lose their ability to do that. So that's just my personal opinion. Hopefully, I think that was Nancy. I hope that answers your question.
Okay, thanks, Suzanne. That looks like the only question we have so far, and I guess at this point I will take this opportunity to let everyone know, if they aren't aware, that we will be uploading the video of this webinar to YouTube, and we'll be uploading the slides to our SlideShare account so that anybody who missed anything today will be able to see all of this after the fact, and we will be sending that out in an email tomorrow, early afternoon likely. That will go out to everyone, whether or not they are here at this point or not. So if you have colleagues or anybody who you think would be interested in the content in this webinar, don't hesitate to forward that along to anybody, or to, put it on your social media or anything like that. So if anybody was wondering, that this will be available later tomorrow for viewing on both YouTube and SlideShare, so you'll be able to take a look at the slides if you just want to see those, or you can take a look at the entire presentation over again. So I just wanted to let everybody know that, and now we're still waiting on any more questions that might be coming in, and Suzanne has just switched our slides to her contact information there, and we also have our contact information, I think, on the slide after that one.
All right, there you go.
Appreciate that. And I did just want to take one more second, because I didn't do this at the start of the webinar, to thank, we have our 3 sponsors for our webinars that we host, and that would be Boehringer Ingelheim, Novartis, and Merck. And so we just want to thank them for making all these webinars possible. And with that, I'm still waiting for any more questions, so don't hesitate, folks. If you do have any questions, if you're not aware, there's a menu bar on the right-hand side of your screen that you are able to post your questions to. And if you do think of any later on and you realize that you should have asked, you're more than welcome to either send an email to us or to Suzanne, and we can get your questions answered. So don't be shy. If you do have a question, go ahead and put it in the questions box, and Suzanne will do her very best to answer it. Bruce just posted asking, just wondering if there are any webinars regarding health insurance and long-term disability. At this point, this is the only webinar that we're hosting on health insurance, but if there is some demand for specifically something about long-term disability, I'm sure we could see what we could do about that. But at this point, this is the only webinar that we have available on on the topic of health insurance. So I think if there are no more questions, we still have 9 minutes left, so I don't want to end too early in case anybody does think of something. But Suzanne, I'm not sure if you have anything else that you want to say before we wrap things up.
No, I don't. I covered most of the topics there, so I was hoping that we have more discussion, but that's okay. You know, give everybody 5 or 10 minutes back in their day.
Yeah, exactly. I mean, I guess we did do a few questions in the middle too, so that contributed to it as well. So hopefully anybody who wanted their question answered then got it answered as well. So I guess with that, we'll wrap things up. We'll let everybody go a few minutes early today. And our contact information once again is on the screen, and we will be sending out the links to both the YouTube video of this webinar and as well as the slides. If anybody is interested in those, we'll be sending those out to everyone who registered for the webinar, whether or not they attended tomorrow afternoon. So at this point, I will just thank everybody for coming today. We really appreciate you coming out, and we hope to see you again for our next webinar. And Suzanne, I'll turn it over to you just to say any final words or thank everybody.
Yeah. Well, thank you everybody for participating, and I applaud you for being interested in this topic and considering your advocacy, and I think that it's really important that we understand this complex subject, and thank you for your participation today, and have a great day, everybody. Bye.
Bye, everyone.